Wonderful. Well, not so fast. Oh, no, no, that's what we said. Please, please sit, because we're going to do just a quick thing at the end. Hold on. CABG has the definitive trials, and that is by Mario Gaudino. Now, many of you, he is our one and only surgeon here, and so he is the endowed Stephen and Susan Weiss Professor of Cardiothoracic Surgery at the Department of Cardiothoracic Surgery at Weill Cornell, and he's also the assistant. He's one of the most academic surgeons that I've known. For the last 10 years, we've been working very, very closely together, and I'm really, really excited that he's here. And of course, he's currently the Assistant Dean for Clinical Trials and the Director of the Joint Clinical Trial Office and Director of Translational and Clinical Research in the Cardiothoracic Surgery Department at Cornell. We're really proud to have you. So go at it. Answer that. CABG has the definitive trial.
Thank you, Roxana. Thank you for the invitation. It's always great to be the only surgeon in a room full of interventional cardiologists, but I hope I will survive. So I am supposed to keep the surgery side. Clearly, I am not sure there are definitive trials, but I will go over the evidence. I have no relevant financial relationship. And look, we can go back really to history. This is 30 years ago. This is Lancet, Yusuf seminal Lancet meta-analysis. And this meta-analysis was comparing CABG with no therapy, essentially. There was no medical therapy in those studies. There was a survival advantage, a moderate survival advantage, I would say, with surgery in the pooled analysis. But when we look at subgroup, you can see how patients with left ventricular dysfunction actually were the subgroup of patients that did better with revascularization, in this case with the surgery. So I agree with Greg that revascularization seems to be particularly important in patients with left ventricular dysfunction. And then Stitch, that has already been mentioned. I have a slightly different reading of Stitch. I think what Stitch show is that even with that kind of medical therapy, for the first 5 years, there was really limited difference between group. And yes, when you extend the follow-up, the difference between group increase and you reach statistical significance. But I think this information is important for treatment decision in everyday practice. So depending on the life expectancy of the patient, you know that probably you don't need revascularization for the first few years, and then the benefit of revascularization become apparent in the longer-term follow-up. And this is important also for the recent PCI versus medical therapy trial that had a follow-up of actually 5 years that Greg has just presented. Then we did a patient-level meta-analysis of the 4 trials that compare surgery with somehow contemporary medical therapy, not contemporary, but at least in those trials there was the use of statin, beta blocker, and aspirin. That was an individual patient data meta-analysis of the 2 mass trial, Bari2D and Stitches, over 2,500 patients, and Greg was seminal in helping us in doing that. And we found overall a survival benefit for surgery, and when looking at the subgroup based on left ventricular ejection fraction, again, patients with LV dysfunction had larger benefit from surgery, even though the P4 interaction was not statistically significant. When it comes instead to the comparison between surgery and PCI, well, really we have no data. We have a ton of observational data. This is from the SCAR registry. But I mean, I have a major issue with observational data comparing PCI versus CABG in general. There is a strong treatment allocation bias, and healthier patients get surgery. So it's unlikely, I mean, it doesn't matter what kind of statistical adjustment you use, the treatment allocation bias is so strong that generally surgery does better, and this is what this SCAR analysis show. And we did this network meta-analysis looking at different treatment strategies, so surgery, medical therapy, and PCI in patients with left ventricular dysfunction. There were 23 studies, but the overwhelming majority of them were observational study, adjusted observational study. And in the plot, you see that surgery did, in fact, better than medical therapy and better than PCI. PCI did better than medical therapy for the reduction of cardiac death. And looking specifically at the comparison between PCI and CABG, you see in the forest plot there was an excess risk of mortality for patients who underwent PCI, and it's clear also in the reconstructed Kaplan-Meier. So there is the issue that we do not have modern data comparing revascularization strategy in patients with LV dysfunction. There are, however, ongoing trials. Stitch 3 is actually an international collaboration of trial from Europe and North America. There are at least 3 of them that are actually in various phases of preparation. We are particularly working on the Canadian one that has been funded last year by CIHR, is now in the startup phase. We anticipate enrollment of the first patient within a few months, but yeah, it will take probably 6 to 7 years before the result will be published. So my conclusion, surgery based on the evidence, on the current data, is the preferred treatment in patients with ischemic left ventricular dysfunction who have extensive coronary disease and good life expectancy, whatever that means. PCI, however, is reasonable in patients who either at high surgical risk, have focal disease, or shorter life expectancy. We do not have high-quality data comparing the two revascularization strategies, but several randomized trials are ongoing, and hopefully in a few years we will have a better answer. Thank you.
Thank you. Thank you so much. Please have a seat.